Good afternoon, everyone. Thank you for joining us today, both in person and online, and for this special live podcast-style seminar. I am Leo Lax at INNEG, and for those of you who don't know us, INNEG helps clinical negligence and catastrophic injury solicitors accelerate your claim lifecycle and reduce unrecoverable costs. Today's event is a collaboration with our colleagues at St John's Chambers, and we're especially grateful for them organising and hosting today's event. We're also pleased that this event is being held in support of CBIT, the Child Brain Injury Trust, whose work supporting children and families affected by acquired brain injury is vital. I'm sure some of you know their work. We hope this session not only informs but raises awareness to the fantastic work that they do. Regular listeners will know that St John's Personal Injury Team has been podcasting on a wide range of topics and more recently have launched a great series of conversations with experts from different fields. At INNEG, we are also committed with sharing knowledge, and some of you will know that we run a regular expert webinar series to help keep solicitors up to date with ongoing clinical developments. Today, however, marks a bit of a departure from both formats. It's the first time that we've stepped outside the studio and into the bear pit of live recording. Anything could go wrong today. Before we begin, let me just briefly introduce our speakers. Firstly, Dr Francesco Manfredonia. He is a consultant neurologist with over 20 years of clinical experience both in the UK and Italy. He has served as clinical director for neurology and neurophysiology at Royal Wolverhampton Trust, and is particularly known for his expertise in epilepsy, neuromuscular conditions, and neurophysiological testing. Alongside his NHS work, he brings extensive expert witness experience, and he is well known for explaining complex neurological issues with clarity. Joining him, on my other side, is Ben Handy, barrister at St John's Chambers, a specialist in catastrophic injury litigation. He's regularly instructed in brain injury cases involving those with subtle or disputed brain injury, and has a particular interest in the intersection between clinical evidence and legal strategy. He's perfectly placed to guide today's discussion from a legal perspective. And just lastly, we're keeping today informal. Think of it more as a conversation, not as a lecture. We'll finish with a Q&A at the end, and with that, I will hand you over to Ben to begin. Thank you very much.
Thanks, Leo. Francesco, thanks for joining us.
Thank you, Ben.
If you're going to expose yourself to the stress and anxiety of live recording, I guess this is the way to do it. We're sitting here on our stools like a boy band.
Yeah.
We haven't got wine in hand yet, but there's the promise of wine and food to come with friendly faces. Before I let you enjoy yourself too much, though, I want to spend some time picking your substantial brain. I come at this, of course, from the perspective of a lawyer, but everyone in this room is interested to hear your take on things as a neurologist. Why don't we start with diagnosis and classification? If you're on shift in hospital and you're told someone's presented with a suspected head injury, what do you do with them?
Yeah. What do I do with them? Yeah, good question. So the first thing I would want to know is how severe the head injury is. So that is kind of the first thing that would inform like management steps. So is it someone that I need involvement of the neurosurgical team? And is it someone that needs like immediate urgent imaging, or someone that to the other extreme of the spectrum, someone then that can wait, and someone that we can just watch and wait, that we monitor, we can review and discharge, or we can even advise the medical team, so someone that we don't even have to see. And in a busy NHS, we get a lot of calls with head injury, head trauma, so we do really need some sort of a compass to navigate our way through and to understand again when we need to step in, when we can let our junior take over, our resident now they're called, not junior anymore. And yeah, and that's probably when issues around the classification become relevant, because there's a lot of classifications out there, so...
Well, let me ask you this. How long after an injury do you typically see someone?
It depends. So usually in a district general hospital, so where there's not like a major trauma centers, it would probably be the emergency department, the ED team that manages the head trauma at the front door. So, and they would probably deal with most of them. So they wouldn't reach the neurology consultant, or they wouldn't like be necessarily reviewed by us.
What investigations will have taken place before you see them?
Usually they would always have like some form of imaging, and the most common is CT scan, so computerized tomography, which is a quick way of looking at gross abnormalities of the brain. So that's predominantly the main investigation, and obviously they would have some bloods, because trauma and head injury happen in a context, and so, and one of the main contexts sometimes is intoxication, for instance. So they would have normally some blood to see whether there's some form of intoxication going on, or some contribution from medications, or and it's very important, like now that we're aging and the population is aging, and we see a lot of people on anticoagulation, so we just need to make sure with a blood test whether if they're taking an anticoagulation, whether they are, what the level of coagulation is, because obviously that is also crucial when it comes to predicting, forecasting what's going to happen, what may happen and what may not happen.
Aging's quite a sore point for me. I had quite a big birthday this week.
Yeah.
CT scans, I mean, we'll come back to scanning later, but they're relatively cheap, relatively quick, and hospitals in Britain are typically set up to give you those.
Yeah.
Okay.
Yeah, they are. Yeah.
You're diagnosing the severity of a head injury using the Mayo classification, is that right?
Yeah. Well, not even. So I think that our colleagues in ED probably, if you go and ask around what is the Mayo classification, they would not be able to tell you.
Interesting.
So I think that the classification is based just on GCS, so this Glasgow Coma Score that, and it's very kind of 3-level, as you all know, so mild, moderate, severe. So that's probably what everybody is going to be familiar with. I think it's very important, and the AD team usually quite careful in terms of trying to get the timing correct. So whether there's been loss of consciousness, yes or no, and for how long, whether there's been like a loss of memory, and for how long. So usually you tend to get this information out of the history, and then you can make up your mind also where the patient is and where he's sitting, and then. But as I said, we need to consider a lot of other variables that may influence final outcome. So we know that the Glasgow Common Scale stratification it's got a lot of limitations.
Well, I mean, we'll all be used to seeing people with either a perfect Glasgow Coma score from the off,
Yeah.
or people that have bounced back and have a Glasgow Coma score of 15 relatively quickly after an accident, but still go on to have some really significant complaints.
Yeah.
So it's quite limited.
Very limited, yeah.
And the Glasgow Coma score is part of the Mayo classification. It's wrapped into it, isn't it?
Yeah.
So how useful is the Mayo classification as a predictor of outcomes?
I think it's useful in terms of distinguishing the two main groups, like the moderate to severe patient and from the mild one. But then once you say mild, you know that they're not necessarily going to be mild. So, and in the mild group, actually, there's a lot of it's quite heterogeneous. So you have really people that do very well and don't require any follow-up at all, and people that go on and on and on for months and months with persistent symptoms. So which usually they fall under different sort of names and umbrella terms, and post-concussion syndrome is probably one of the main ones that the neurology community is now trying to discourage as a terminology, because it doesn't mean much, so it doesn't really tell the story. So we prefer to understand what is the symptom complex and how it declines, so in that single individual. But yeah, the main point is that the mild is very different and very heterogeneous. Yeah,
it's almost a misleading word.
It
covers a multitude of things.
Yeah, and it almost like refers to in the mind of people who like not very familiar with the trauma. It also feels like it is going to be the outcome. So mild is going to be what actually is eventually the outcome, which is not, as I said, is not always the case. And
certainly as lawyers, we are used to seeing people who might have suffered quite an innocuous head injury, but go on to complain of very significant and long-running symptoms. Does that accord with your clinical practice then?
Yeah, absolutely. And these are probably the one that we tend to see the most. So the one with mild brain injury at the start, but that go on to develop severe neuropsychiatric, behavioral, and physical symptoms. So they tend to be reviewed by the neurology team. And another, I was going to say also, there's a bit of a stigma around the use of these terms mild and moderate severe, because if you tell someone with a mild brain injury with a post-concussion syndrome that they have a mild brain injury, no, I don't think they're going to be happy to hear the term mild.
Or worse, they might be told they haven't even got a mild brain injury.
Exactly. And the same goes for like people with moderate to severe brain injury, because they can do very well. So and sometimes when you use the term moderate to severe, it can lead to a sort of nihilism. So like, I'm not going to do anything about him. It's just it's something of a stigma that I think from a patient perspective has been sort of put into question in recently as well.
You mentioning this, I'm sure when I looked at this recently for another podcast, I found a study that had said, I think most people that had been diagnosed with mild brain injury were still having problems at work, or weren't working normally, even 5 years post-accident.
Yeah.
So, as you say, the words mild, moderate, severe might not be the most helpful language. I guess they're talking about the acute phase of the injury rather than the chronic phase. Is that fair?
They're talking about acute, which is, as I said, necessary sometimes to take the first steps. So, and to understand also where the patient needs to go. So, if you need to involve like a major trauma center and move the patient to a major trauma center where there's a neurosurgical team ready to operate on. So it's probably useful in at the front door, but then after that, I think after the first 6 hours, it is becoming confusing, misleading, and probably I think,
not just not useful, but positively unhelpful.
Unhelpful, I think, yeah.
Possibly also for lawyers and judges, because we're not
Absolutely,
experts. We don't necessarily have the immediate appreciation of the limitations of that language that you as doctors do.
Yeah.
Do other countries use the Mayo classification?
Yeah, I mean, they use the Mayo classification, and I think there probably some countries in Europe are even ahead of the Mayo classification, because they are starting to incorporate in their guidelines other metrics, other way of assessing brain injury, so not just on response to verbal clue or like to the eye opening or so, but more kind of they're looking at some specific blood tests that you can do and then correlate with brain damage. They look at some form of imaging like MRI scans done more kind of close to the injury rather than later on. So if you happen to have a brain injury, let's say in Norway or Sweden, you probably get a much better stratification of your brain damage than you get in UK or in other countries in Europe. And even in the States, so there's a lot of variability from going from north to south, east to west. So, yeah.
There's been some interesting talk, I know we've spoken about this, about the National Institute for Health in the US, who are trying to develop a new system of classification that does take into account not just your imaging, not just your history, but biomarkers.
Yeah.
And I forget what the fourth pillar
and the
was.
modifier. They call it like, they use this nice term modifier. So basically what they're trying to propose and is a different sort of classification, which is sort of multi-modal, multi-dimensional. So it's not just on based on consciousness level or response level, but incorporates, as you say, like other pillars. One is blood tests, so there are specific proteins, enzyme you can test for in your blood when you had
in a time-limited way? Must it be done soon, or are
not
there things
necessarily.
that...
So there are studies that show that there's value in doing this test also, like later on. So even if you come across a patient 1 month after the trauma or like 2 months afterwards, there's still some sense in doing some of the blood. So they're quite sensitive to identify brain injury in people that have, for instance, normal CT scan. So, or going even a little bit back at the front door, if you have a patient with mild head injury and you want to avoid scanning everybody, and so if you have this blood test, you can stratify the patients that are more likely to have a positive, so an abnormal CT scan from the one that are more likely to have a normal CT
and prioritize who gets the scans.
And prioritizing, and so I think these blood tests and 3 or 4 of them with fancy acronyms, but they're quite, as I say, sensitive, not specific. So there's an issue around the specificity, which I can address if you want. But the other thing is using early use of MRI scan rather than CT scan, because at the end of the day, every emergency department has now MRI scans that operate 24 hours, 24/7.
But it costs to get them?
It costs, but I think in some cases, if you can stratify the patients that are more likely to have brain damage with a normal CT scan, and it's probably worthwhile to at least use the MRI scan for some of them, like you do with patient with query stroke, so they don't go inside. Some of them just go directly inside an MRI scan, and they don't go inside a CT scan. So I think we're gonna see an early use of the MRI scanners even in UK. So obviously, Scandinavian countries, or I mean, have MRI scanners like many more scanners than in ED than in UK. So they've got this advantage. But
It's obviously a noble aim to try and improve the classification of brain injury and improve how predictive that is of outcomes.
yeah,
We're clearly a long way from that now, though.
It is quite a long way, I think. It's quite a long way, and I think it's the intention is good. So the way the classification works is quite complex, because if you look at the clinical pillar, you have not just the Glasgow Coma Score, but also the reactivity of your pupils. So we know that if you shine a light in your eyes, and the pupils usually tends to get smaller, and it has to get smaller on both sides, and the response to the pupil is a predictor of the outcome. And that's the clinical pillar, which is based on Glasgow Coma Score and on the reactivity of the pupils. But on the Glasgow Coma Score, repeated Glasgow Coma Score, not just 1 point entry, so not just like one assessment, but a repeated assessment, because it is acknowledged that, as you were sort of suggesting before, that it's not static. So you have a patient that at 6 hours is 15 and goes to 14, 13, and so you need to repeat the Glasgow Coma Score. And then the biomarkers and the imaging, and then finally the modifiers. So the modifiers are really, really important. I think it's probably one of the main novelties of the classification, because you just acknowledge that everybody has some sort of specific vulnerabilities, and so if for instance, we were saying before, if I'm an elderly gentleman with balance issues related to arthritis, and I'm on anticoagulation for heart problems, so obviously my head injury is going to be more at risk of deterioration than your head injury, because you're younger and you don't take anticoagulation, and your brain is not shrunk. So
it makes perfect sense what you're saying, but these things aren't part of the Mayo assessment at all.
No, they're not.
No, okay.
No.
I mean, as lawyers, we're all familiar with the suspicion that's baked into the legal system. So if you've got someone with a really serious brain injury who goes on to make a relatively good recovery, they're in a good position as far as their case goes, because no defendant's going to have a problem with that. But those significant proportion of people who've been diagnosed with either a mild injury or something short of that go on to have really bad functional issues, they've got a hurdle to overcome. Maybe not allegations of dishonesty, explicit, but still they have to satisfy a judge or a defendant team before they make them offers that what they're saying is accurate and that it's causatively linked to an accident. Do you think those people are overrepresented in the medico-legal population as opposed to your clinical population?
I think they are. I think there is an element of when it comes to litigation, probably it does potentially contaminate the picture, and but there's also like a sort of cognitive explanation for it. It doesn't have to be related to the honesty, dishonesty. It's just that there are people that are more like a sort of attention system is more focused on these or that symptoms, And if you expect to suffer from one symptom, the brain is made in a way that you most likely to suffer from that symptom. So if you expect to be dizzy when you take the elevator and you go like into the top of a skyscraper, that you're gonna be dizzy. So that's how the brain works. So, and it's
not a question of honesty. It's just it's the subconscious.
Yeah, exactly. It's more kind of we have built in our brain like a sort of systems of attention. For if my brain is seeing one bit and seeing the candle, and I think fire, I think danger. That's how the brain works essentially. If I don't see it, I don't think about it. I don't think about the danger. I don't expect to be a fire, like a fire alarm. So it's all about attention system. So it's not about dishonesty, and the litigation obviously introduced an element of my life, my thinking mind is probably focusing more on these symptoms rather than someone else.
Yeah. Let's talk about imaging. The Mayo classification focuses quite heavily on the results of imaging, whether there's an objective sign of brain trauma on scans.
Yeah.
And we're used to seeing the results of CT scans, maybe a bog standard 1.5 Tesla MRI.
Yeah.
We know they're not perfect. They don't pick up all the damage that there is to be found.
Yeah.
Is that how common would it be for patients to have something more than that, some other kind of scan in your clinical practice?
I think if obviously a patient continue to complain of symptoms, whether that be neurological symptoms or even non-neurological symptoms, they go on and have an MRI scan, and there are some, when you do an MRI scan, it's basically taking a picture of the brain, and you can take a picture using different filters, so from different perspective. And there are two specific filters that are very useful in terms of assessing like subtle damage or small damage that would elude a CT scan or even a conventional MRI scan.
What are they?
So there's two of them that you probably will come across. One is called diffusion tensor imaging. So, and it's basically look at the movement of the molecule of waters, and they have to move. So water needs to move, our molecules need to move. If they don't, it means that there's an area of inflammation. And this kind of diffusion tensor imaging are very sensitive to pick up area of inflammation. And usually in a patient with an head injury, that inflammation corresponds to area where there's been like a shearing of the nerves, so that the CT scan doesn't see, and that the conventional MRI scan would not be able to pick up. So,
how readily available are the? Is the technology
technology-wise, you just press a button, but you need to know that this is a button you need to press for a head injury.
I expect you would hear from the people in this room that if you're going to go for a DTI scan, it's going to cost a lot of money, and there's only limited places that will offer them. Is that your experience as well?
It's not. Like,
interesting.
I think, obviously, I mean, doctors don't worry too much about costs. So, and I know that it's one of my limitations.
You heard it here first.
Yeah. So it's my limitation, and I don't go inside a cubicle thinking, oh, this is going to be expensive. Or I think I go inside saying, I need this. This is going to be more useful than that one.
So do you have the technology in Wolverhampton?
Yeah, we do.
And if it was fed back to you via legal team and then a clinical team that this person could do with a DTI scan. That's something you would sign off via the NHS.
Yeah. I mean, it's perfectly doable. So it's, as I said, it's a type of sequence. So that basically, you just need to have a technician that knows how to handle the scan. But it's built in every software. So when you buy an MRI machine, so you buy software, and in this software, the diffusion intensive imaging is just like really a button. So it's a 3-4 minute sequence that is very common, not because it's the first sequence we use when it comes to assessing people with query stroke, because first positive findings that you have in people with stroke, you actually find it in a diffusion intensive imaging.
Right.
And there's another probably imaging modality that you will.
Well, before you move on to that,
okay,
in terms of interpreting a DTI scan, is that something a neurologist like yourself would be quite comfortable looking at and interpreting, or would you definitely be passing on to neuroradiology?
Obviously, if you got a neuroradiologist on board, then makes things much easier and quicker, because you can rely on a report and you don't necessarily have to review the scans the way. But I think as we are very much accustomed to look at scans ourselves, so not because we don't trust our colleagues, but because a lot of district general hospitals, even in tertiary centers, the scan is not going to be reported necessarily by a neuroradiologist, so they may miss something that actually we are more accustomed to see, or we know where to look, because the thing is that there are some areas of the brain that are particularly vulnerable to acceleration, deceleration, so to the mechanism of trauma is quite crucial. We didn't touch on that, but if I know that the kind of the mechanism of injury of the brain, and I know that probably this area of the brain that called corpus callosum is the one that I need really to look at with attention and with the magnifying glass, because we got the magnifying glass when we look at the scan. So
you have to look at the right.
Yeah, I mean, you have to look at that place, and if you don't look, you're more likely to miss it.
And I'm sure we're reasonably familiar with the idea that there are certain kinds of mechanisms, as you say, that might lead more readily to things like a diffuse axonal injury or something that's harder to pick up on your traditional scans.
Yeah, absolutely.
And those are normally, I'm going to get this wrong, but they're normally your rotational forces.
Rotational forces or acceleration and deceleration. And the reason is like I'm not a physician, and I was very bad at math, but when you look at the brain, basically, you got, I'll try to make it very, very simple. So maybe if it is too simple, I apologize. But you have your gray matter, which is like, it's got its weight and density. And then you got your white matter. So with gray matter is your neurons, so you what really matters. The white matter is basically your cables, so they connect all the neurons.
They still sound like they matter to me.
Yeah, it matters a lot. It matters a lot, but they got a different density, a different weight. So when you suffer acceleration, deceleration for reasons related to gravity, and that's as far as I go in terms of explanation of the physics, the junction between the gray and the white matter is really a vulnerable point. So where you tend to have shearing of and actually breaking of not just of the outside of the neurons, so the protection, the sheath of the nerve, but also the structure that is inside the neurons, and that can cause what I heard you describe in one of your podcasts, this cascade.
Yes, I'm going to ask you about that.
Yeah, I knew you would.
Other types of scan we might come across, you've got your 3T MRI, a bit more, a bit of a higher resolution.
Yeah.
Meg scans,
you
might have heard of.
I think these are more sophisticated compared to, so when it comes to like, if you say 3 Tesla MRI scan, it means that basically you go from a Kodak machine to a real, camera machine. So you increase the power of the scanner. So it's not a software that you use, which you can use in a Kodak machine. So because you just have to press a button. Probably more than using a 3 Tesla MRI scanner like the MAG scan, which is something even more sophisticated, and it's not that useful, I think, in the assessment of head injury. You would want to look at other kind of sequences. So basically, in your software, you still have other buttons that you can press. And can tell you other.
This is technical.
It's technical, yeah, very technical. Yeah, I'm not a technical guy, so but I know that if you press another button, and then what you can look at is, for instance, if there've been any microbleeds, and that's really important for us. So if we see that, because a conventional MRI scan can miss it. Whereas if you do this called susceptibility imaging, you can see actually these microbleeds very, very well. So they're like little black spot, and they can be in a critical part of the brain. So, and that changes completely the sort of the approach to the patient. And I guess it gives you some sort of evidence or correlate
confidence,
comfort in saying, well, actually, he's complaining of this, and it's got all these spots. And
how time critical are these? Can you come to these options months, years down the line and still find evidence?
With the susceptibility weighted image, now I'm going to call it SWI because it's easier. The microbleed, they usually you can see them even months afterwards.
Interesting.
Yeah, because when the blood products degrade, they can leave a mark, sort of, which can be assessed with this like software. Diffusion is different because inflammation comes and goes, so it doesn't last forever. So and the brain is capable of repairing itself, or at least especially in young people. So obviously, but it wouldn't leave a scar necessarily. So diffusion weighted images tend not to be that sensitive if they're done too further down the line, whereas SWI are more kind of sensitive even in the long term.
I suppose even with all the resources in the world and the best will in the world, you might not always find the objective evidence of brain injury that maybe a patient or their lawyer is hoping to see.
Yeah, yeah.
And so sometimes you are left looking for other clues about the presence of brain injury.
Yeah.
I know that audiovestibular assessments can be useful as almost a secondary sign of the presence of a brain injury. Can you maybe explain that for us a bit?
Yeah, I think it's basically when you have a head injury, most likely the vestibular system is going to be affected. The vestibular system is basically a tiny part of the inner ear, where it's crucial in controlling our balance, and especially the movement of the eyes in relation to the movement of the head. So there are some tests, the vestibular tests that you can actually do, and there's no line about those tests.
You can't trick them.
You can't trick them, so they can provide you objective evidence of damage to the vestibular system. And because the vestibular system, the inner ear is inside the brain, it's not part of it's not considered part of the brain, it's part of the it's the inner ear, so it's what we call end organ or peripheral organ. Well, most likely if you got a damage of a structure which is like a few millimeters big, I think most likely you would have damage to the brain as well. So that's how, as a neurologist, tend to think. So.
And then we're familiar with the other signs and symptoms you might be looking for, such as nausea, dizziness.
Yeah, then less specific. So obviously all these signs in terms of the dizziness, the fatigue, the headache.
I mean, fatigue's a huge one.
Fatigue is a huge
It seems
one.
to me to be like the single biggest complaint you get from people is just
Yeah.
how the fatigue affects them.
Fatigue, yeah, but it's very kind of difficult to sort of provide evidence for it, right? So
You're dependent on
independent.
basically someone being believed.
Yeah, yeah.
Loss of consciousness and post-traumatic amnesia are two signs that are elevated over those other signs.
Yeah, they are. But the problem is that in the real world, oftentimes you don't have that information,
Yeah.
or it's not accurate enough. So
That's right. At least one of the authorities talks about an eyewitness looking at the claimant post-accident and saying they seemed fine,
fine, yeah.
but the finding was in fact this person
Yeah.
had a loss of consciousness. They
Yeah,
were there, but
Yeah.
people aren't actually very good. Lay people aren't very good at
Yeah.
deciding whether someone
Yeah,
is really
yeah.
all there or not.
yeah.
Some of the takeaways from the recent big cases include things like very, very short periods of loss of consciousness or post-traumatic amnesia being sufficient to give you that confidence to give someone a mild diagnosis, a mild brain injury diagnosis. One of the other things that's come up is how post-traumatic amnesia might not follow immediately after the event. It might come on hours or
Later, yeah.
and I think that feeds into neurometabolic cascade. Which you referred to earlier.
Yeah. It's although it's an hypothesis, so it's not something because you don't go and test chemical neurotransmitters in the brain of people with head injury. So it's more kind of it comes from cell studies or animal studies or experimental models. So it's not.
So there is evidence for it.
There is indirect evidence.
Indirect evidence.
Yeah, it's not like, but definitely something happens, and if you look at like we've been mentioning before, the structure of a neuron. So if there is an injury to your brain cell, that may trigger some sort of even processes of we call, it's a big word, apoptosis. So basically you may by mistake switch on the mechanism that leads your brain cell to sort of assisted suicide. So that's a real phenomenon. So brain
and the real world effects of that, anything that I would see from the outside looking at you, might not kick in for some time.
No, it won't.
Even though the chemical process has been set off by the accident.
Yeah, exactly. Because the chemical process itself takes time, so you won't see it immediately.
I'm conscious of time. We haven't got ages. I feel like I could talk to you for ages. I'm interested. When you can't find objective evidence of a brain injury, how involved are you in someone's onward care? Do you pass them on to, I don't know, neuropsychiatry, neuropsychology, another? Or are you still involved in their care for some time thereafter?
I think we remain involved because what we're trying to establish also, there's always an easy way and a hard way. So the easy way could be I just refer to other specialties and wash my hands, and that's probably I shouldn't say in a podcast, but that's a bit of the reality, and then you move on to the next case. But I think if you want to do a good job, I think you need to have an holistic approach, and you can't ignore like that patient is telling you, I can't do the things I used to do before, or my memory is not great anymore, I forget things and I can't go back to work. So you're still very much involved, and what you need to understand is whether the head trauma has caused some cognitive problems. And that's the realm of neuropsychology. So you need like some battery of tests where you can assess your memory, you can assess your executive function, you can assess your whatever domain of that is affected. And each cognitive domain can be assessed with a battery of tests where you got a range of normal and a range of abnormal. And the tests that we use are quite structured, and so much so that it becomes almost a piece of objective evidence, because you can spot inconsistencies or
particular areas
areas.
Someone might have a deficit in. You'd expect to see similar deficits in other areas and not others.
Yeah,
but your continued involvement, is that, I suppose, a reflection of the fact that not all brain injuries are going to be picked up on the imaging? So you're accepting that you need to have that buffer, accepting that someone may still have a brain injury.
Yeah, absolutely.
And therefore your involvement is still required.
Yeah, and then you need to understand, is it cognitive, is it behavioral? So you need to involve neuropsychiatrists, you need to involve a psychologist. So I think it's also to understand what next for that patient.
I'm going to hand over to questions in a sec, if there are any. But before I do, tell us the difference between a neuropsychologist and a neuropsychiatrist, please.
Yeah, it's simple. So
in one sentence, one sentence.
Yeah, so the neuropsychology do the test to assess your cognitive function. So how good your memory is, how good your language is, and neuropsychiatry look at if you're depressed, or if that event is trigger you some anxiety, or so it's more the kind of orientated is based.
Good. I'm going to clip that and play that whenever I'm asked in future. Are there any questions in the room? I have one or two for you myself.
Yeah.
What mistakes do lawyers make when we instruct you? What can we do to make your life as easy as possible?
I think I need to understand the circumstances of the trauma, what exactly happened, and what is possibly the mechanism of injury. It's probably not that. Sometimes you need to go and look at the notes yourself and to try and dig that information. Sometimes it's very much.
But the notes might not be reliable, or not paint the full picture anyway.
Absolutely. So I think the circumstances around head injury is really important.
So what, you might have more detailed instructions, or you might have a short statement from the client, or something like that, focusing on mechanism
that
in
would
particular.
be really helpful. That would be really helpful.
One last question. You're both a practicing clinician and you do medical legal work as well.
Yeah.
I'm interested in how they complement each other, how they feed into each other.
Well, I found the medical legal work very fascinating, and I think probably you learn a lot about what is like someone with a head injury in relation to society, essentially. So you put a patient into a larger context, and it's nice sometimes to see that people can be supported beyond the here and now. So I don't know whether I answer your question, but I think it's complementary with me, and it's quite intriguing to.
Well, Francesco, let's wrap up there. Thank you very much for sharing your experience with us today. I'm sure I'm speaking on behalf of everyone here when I say that was fascinating, and we really appreciate your time. If you're ever hosting a neurology podcast and you need a sleep-deprived barrister to be a talking head for you, I owe you one.
We consider that.
And I think there's food and wine waiting for us outside, so let's go and spend some time with some friendly faces. Thank you very much.